Again we are live. I am live from Dubai, and today we have Professor Karim Sabry from Egypt. He is a well-known bariatric surgeon at the globe, no doubt. His role for promotion of bariatric surgery education really appreciable, and in my opinion, this is great opportunity for our youngsters to learn from such a personality. And also it's great honor for me to interview such a prestigious figure. My viewers, as you know, so we have started this interview series with the MGB OAGB for 6 months, then safe sleeve gastrectomy and Rowan by gastric bypass, and we have started this metabolic surgery in low BMI diabetic patients since July 2022 with Professor Alper Chilik. We interview big names like Antonio Torres, C.K. Huang, also Professor Surendra Ogale and many. And tonight we have a practical man. We have Professor Karim with us. Sir, really it's great honor for me. Please sir, over to you.
Thank you very much, Professor Omran, for your kind invitation. Thank you so much for your followers for following this amazing series of lectures emphasizing on specific and important topics. Again, it's an honor and a privilege to present in this great academy. Actually, you are doing a great job and working hard to spread knowledge all over the world through this great academy. Thank you very much for you.
Sir, great honor mine, really. This is the reality, really great honor, because I know so every person is so much busy, but so far, sir, in my opinion, this is a great job, especially from your side, because you will share your knowledge, and this is the practical thing. And in my opinion, we are at least 5 years ahead to a book. So when this knowledge will be a text, it will take time. And now you are sharing your practical things, and definite this is a great job, especially a person like you when share your knowledge. Sir, we have divided our question in 3 parts. In first part, so definitely your brief introduction, and also we will talk about patient selection. That is also very important, because especially in low BMI diabetic patient. In second part, we will touch technical points, and in third, your data, your experience. So you can also share at any stage, you can share any slides, also your video. Sir, please, your brief introduction.
Okay, thank you very much for your introduction. And can you see now?
Yeah, I can see, sir. We can see.
Okay, so we can get started now. This is a lecture that will cover all aspects of this hot topic about metabolic surgery in low body mass index and how we can do it. I have no disclosure, and we can start by these facts. Diabetes mellitus is increasingly an alarming rate and has become one of the major causes of mortality and cardiovascular events worldwide. So the current guidelines recommend a multimodal approach like lifestyle modifications and hypoglycemic agents. However, fewer than half of the patients with diabetes can maintain the therapeutic goals of glycosylated hemoglobin lower than 7% of total hemoglobin under currently available medical remedies. So we can also observe that diabetes can attack the eye, can attack the kidney, can attack the micro and the macrovascular vessels in the leg, and all attacking all the body micro and macrovascular vessels. Just a few years ago, the use of insulin was the last line of treatment for type 2 diabetes. Currently, the guidelines are completely different. The management is based on early diagnosis and early prescription of the most effective treatment. And we can notice the long journey started since 1930s by observing that patients who underwent Bill 1 and Bill 2 as a treatment of gastric ulcerations was totally free of diabetes on the second day. But the surgeons at that time didn't know why this happened and what are the underlying physiology behind that. Through this journey till we reached 2022, we are searching about theories to underline and to emphasize what is the importance of bariatric metabolic surgery, surgical operations in the management of diabetes. So these facts, like bariatric surgery is the most and more effective than medical treatment for long-term remission of diabetes type 2. And also it leads to substantial weight loss and to also vascular and endocrine associated comorbidities improvement and remission. Type 2 diabetes improves at an early point after surgery, even after the first or second day post-operative without weight loss. There is independence of glycemic control from weight loss and absence of correlation between diabetes relapse and weight gain. Even after remission, the relapse not related to weight gain after that. So this demonstrating the efficacy of metabolic surgery in type 2 diabetes remission for patients with moderate obesity, body mass index 30 and 35 kilogram per square meter. These facts have quickly led to establishment and spread of the concept of metabolic surgery. And also the American Diabetic Association did a statement 2016 about the importance of metabolic surgery at a low body mass index 30 kilograms per square meter. Several evidence-based facts from numerous randomized controlled trials support new guidelines that advocate the consideration of metabolic surgery as one option along with lifestyle and medical therapy to treat type 2 diabetes mellitus patients with body mass index less than 35 kilogram per square meter. Different maneuvers between laparoscopic Roux-en-Y gastric bypass, mini gastric bypass, and sleeve gastrectomy sleeve gastrectomy are also, they are an important and very common procedure we are doing nowadays to combat diabetes and also obesity. But we are in a dilemma between these procedures because we don't have the actual or the direct guidelines that emphasize one of them to be more beneficial than the other one. But we did know that from this angle, the best procedure tends to be biliopancreatic diversion in management of type 2 diabetes. However, it has the worst metabolic deficiencies such as anemia, vitamin deficiency, uncontrolled weight loss, protein malnutrition, bad offensive stool, and several diarrhea. So we don't do it as a private in the private sector. We do this procedure till now, especially in Egypt, in the university basis for research only. But we are doing mini gastric bypass, Roux-en-Y gastric bypass, sleeve gastrectomy are the most common procedures, and also we can choose the ideal technique for diabetic non-obese patients and calculate the efficient glycemic control against weight loss. Should be mild to avoid other deficiencies installment. Also, we are doing a lot of investigational procedures nowadays, like SASI and SASJ, and also your technique. You developed a new technique, placated SASI, and so you are elaborating on this many times. The last time is today. You elaborated on this, and this newly developed Sleep Plus procedure that may avoid the adverse effects of older procedures. As regard vitamin deficiencies, excessive weight loss are still under investigation to achieve balance between anti-diabetic effect and weight loss. Many reports provoke the efficacy and safety of these procedures in obese type 2 diabetic patient as a treatment. This is my work is 45% sleeve gastrectomy, 20% Roux-en-Y gastric bypass, 50% is mini gastric bypass, 20% redo cases, and start lately doing robotic bariatric procedures. This is our own work and our own publication about metabolic surgery. Started by this 2019. We did mini gastric bypass procedure in a patient who have blood mass index between 25 and 30, but they were 17 patients only. We did mini gastric bypass with a bilipancreatic limb, 120 centimeters, and we followed those patients for 2 years. And we found that single anastomosis gastric bypass is an efficient metabolic procedure and could be integrated in the treatment algorithm of type 2 diabetes. But we had limitations in this study at the time. This was a small number of patients, 17 patients only, and also we did follow-up for 2 years only. So we need more follow-up after that to ensure that it's the best choice for those patients. Also, we studied also laparoscopic sleeve gastrectomy, and we published about the early metabolic effects of sleeve gastrectomy as regards diabetes, hyperlipidemia, and also fatty liver. And we found that it plays an important and effective role in correlation of metabolic disturbances associated with obesity. Also, we studied the 2017 SASI, single anastomosis sleeve ileal bypass, and we found that it's also decreasing weight and also it affects and improves the associated metabolic consequences. 2021, we published 1 year ago about the efficacy of SADIS versus mini gastric bypass on type 2 diabetes. But we found that we followed those patients 1 year after the operation, and we found there is no difference between the effect of SADIS and mini gastric bypass as regards type 2 diabetes. Maybe the difference will be in the future, but during this follow-up period, we found there is no difference between SADIS and mini gastric bypass. So, how can we select and prepare our patients? We followed the criteria of the metabolic surgery that was, they followed the joint statement by the International Diabetes Organizations since 2016 till now, adopting this techniques and this statement. But we can follow this diagram and emphasize the market part that they stated from 2016 that class 1 obesity from 30 to 34.9 was uncontrolled diabetes. They advocate that they will benefit from doing metabolic surgery at the time. Since 2016, we are doing and following these guidelines. We know that there were guidelines recently published in 2020-22, 1 month ago, about the new guidelines of the metabolic surgery, and including the American Society of Metabolic and Bariatric Surgery and EFSO. They stated that we can start doing bariatric surgery as a metabolic surgery starting with body mass index of 30. Actually, we did a lot of investigations, routine investigations, and also we can emphasize that the importance of hemoglobin A1C and also the C-peptide and fasting insulin level, HOMA, anti-GAD. Anti-GAD can differentiate between type 2 and type 1 diabetes. HOMA can be of importance that predict the remission and also the recurrence rate after that. And this is a paper indicating the importance of C-peptide. If it is more than 3 nanogram per deciliter, it will be a positive predictor of 3-year post-operative diabetic remission. We use a lot of scoring system. For example, Diagram score, who included the age and hemoglobin A1C and other and calculating the diabetic drugs, including the insulin, and gives a score. If it is between 0 and 2, it will increase the incidence of diabetic remission to be 87. If it is 3 to 7, it will be, the remission rate will be 66. And also we can follow this score. This diagram score not including the duration of the affection of diabetes. So this is the advanced diagram scoring system. This is the same, but he added also the diabetes duration, which has a great effect and a great impact on the prediction of long-term diabetic remission after Roux-en-Y and sleeve gastrectomy and adjustable gastric banding. We can now scan this QR code or take this link. This QR code is an online calculation of the advanced diagram score. It's available online. You can enter the data of the patient, and on time he will calculate the rate of remission or the percentage of remission after calculating the parameters entered in this link or this online remission score calculator, including the age, type of surgery, hemoglobin A1C, insulin treatment or not, and diabetic drugs, and number of anti-diabetic drugs, and diabetic duration. This is very important. So if we will be asked about what type of operation will you provide for the patient, we will consider the benefit and risk for each procedure, and also we can assess the commitment of the patient for follow-up, and also according to the expertise and the experience of the bariatric surgery, you can search for the best and safe procedure, and also the patient general condition with which we can predict morbidity and mortality. So we can consider also the simplicity and reversibility of the procedure. We can also use the diagram and advanced diagram score for help to choose the best procedure for the patients. According to some parameters, this was an individualized metabolic surgery score. He can choose or help to choose between sleeve and Roux-en-Y. This is published also in this link, and this online calculator, it's also available. We can scan this code, and he divides according to the preoperative number of diabetic medications, preoperative insulin use, preoperative duration of diabetes, preoperative glycemic control. He can divide online its mild or moderate or severe case, and also he can provide a summation that you have to choose sleeve or Roux-en-Y gastric bypass. This may help. So after that, we can share other surgical technique. I can let you to discuss anything or to ask any question, and then we can proceed for the surgical techniques in a videos. Each procedure will take 2 minutes.
Sure, sir. So please, you can click this stop sharing.
Okay. Sorry.
Stop sharing. We have a.
Okay. Stop sharing. Okay.
So excellent. Really, Karim, it was amazing because in detail you highlight, especially patient selection in low BMI. I have one question because our target is low BMI. Is it routine to rule out any autoimmune impact?
Sorry?
Like GAD or islet antibody, are you rule out LADA in these cases in routine or no? Low BMI. I am talking only low BMI.
Yeah. You are talking about, I don't hear well, but you asked about routine anti-GAD and routine C-peptide and HOMA. Yeah. So after routine investigations, we are using hemoglobin A1C. If it is high, it indicates that this patient will have a high rate of recurrence, and it will not have a very high or very good percentage of remission of diabetes according to diagram and advanced diagram score. And also, it's a routine for us to see the reserve of the pancreas by doing C-peptide and fasting insulin level. If it is more than 3 nanogram per deciliter, it indicates that there will be a good response for remission after doing the operation. But according to the advanced score that we showed last slide, they said that if you found that the patient has a very bad parameters as regard many parameters, you can choose between types of operation according to the results of the hemoglobin A1C and C-peptide. It will make very big difference between choosing sleep, for example, or doing Roux-en-Y gastric bypass, or doing any other malabsorptive procedures.
Yeah, I agree with you, because in this advanced DARIM score, also they mention HbA1c less than 6, then it will take 0. So are you because that just we are talking for low BMI, not for a obese patient. So when we are doing a surgery for a morbid obese, so our target is also so definitely to lose weight. But now a patient is low BMI, HbA1c is less than 6. Are you go for surgery in this case?
It's a very big. My opinion is for metabolic surgery is not only to cure diabetes, it's also the aim to cure or making a remission as a percentage for hypertension, dyslipidemia, fatty liver. And it's not only for diabetes. I see the latest guidelines or the latest publication from the EFSU and also the American Association of American Federation of Diabetes. They don't state that the patient above the 30 should have uncontrolled diabetes in the latest guidelines. 2016, they stated that you have to do metabolic surgery if the body mass index is between 30 and 35 with uncontrolled diabetes, severe uncontrolled diabetes. So nowadays, if I see that one patient who have hemoglobin A1C less than 6 and it's body mass index between 30 and 35, I will go for weight loss beside targeting the other metabolic adverse effects or the other metabolic diseases like diabetes, hypertension, dyslipidemia, fat liver, and these all are indications. So if the patient is body mass index between 30 and 35, I will go for surgery.
So definite, sir. So now why I am asking this, because we have also a lot of viewers who are youngsters. Because I remember, so this now 1 decade before, so there was not such a hot topic for metabolic surgery in low BMI. And also we always mention in uncontrolled diabetes, so surgery was last option. But as I can see the results, so definite we are going to do surgery till in diabetic patient. So now HbA1c is not a selection criteria, especially so if okay, when patient is taking so many medicine and also injecting insulin, then HbA1c is lower than 6. So then with surgery, then no need to any medicine. So also, as you have mentioned, also protection for that microvascular complication. So definite, so this is the time, especially for public awareness and also to discuss with our diabetologists. So, okay, patient is controlled diabetes, but with these medicines. So when we will go for such a patient like BMI 30 plus, then we will go.
After that, I see a lot of patients are not candidate for surgery below 30. If you found this patient is very poor, ignorant, he cannot follow up with you after the operation, it will make a lot of problems. And also without vitamin supplementation, he will lose more weight. He become complicated by vitamin deficiencies and become complicated by severe protein malnutrition, and he will return back for reversal in a short time. So I feel from those patients below 30. Above 30, I'm now adapting the guidelines if there is complication, he will come back again. For me, according also to the guidelines, I explained everything according to the guidelines of the EFSO and also to the American Federation of Diabetes or the societies that stated the guidelines. I'm not sure. I'm not doing metabolic surgery below 30 anyway.
It's good. It's good because, sir, as you have mentioned, so maybe again we will also will be at that side of curve and decline, and that is also dangerous. So if patient will lose more weight and micronutrient deficiency, so definitely if we will follow these international guidelines, we are also in safe zone, and also patient is also, because patient safety is more important. Sir, please, so you can highlight your technical points if you have any video, please, sir.
Okay, so we can show screen now.
And also you mentioned in low BMI you are going to do MGB with BP limb 120. That was interesting, really.
No, it was also it was only a study. But if I am doing my technique in MGB in body mass index between 30 and 35, I will make the biliopancreatic limb not less than 150. The study design at that time was for body mass index between 25 and 30. So we did the biliopancreatic limb 120, but we didn't do nowadays any body mass index below 30. So in my practice, if I am doing mini gastric bypass, I will design the biliopancreatic limb not less than 150 if it is between 30 and 35. But above 35, I'm doing excluding 2 meters as usual in my practice. To make it clear, because I'm not doing 120 centimeters.
Yeah, sure, sir.
So there's a different videos, short and live videos about the techniques of many procedures. Starting by sleeve gastrectomy, we have to deflate the stomach by introducing the bougie. We are doing now separation of the omentum from the gastric pouch, from the wall of the stomach. And this is ligature, the device. I love to do all my cases by this device. And also, this herb went to the lesser sac, and also excluding in a hiatus hernia at the hiatus, and also a complete mobilization of the stomach was done. And we started 4 to 6 centimeters from the pyloric ring to preserve a cuff of antrum to avoid this motility of the stomach because of excessive antral resection. 2 green reloads and 1 gold, and then completing with blue reloads. What's new is we added and we published about the Augmented C and its importance in 2018. This technique helped us a lot to avoid many leakage and prevent a lot of bleeding cases, and also prevent twisting. This is omental fixation with whole thickness stitches. It's a very good technique, and we published about it before. So I advise anyone to try this. This is cheap, and this is fast, and this is safe, and prevent 3 most important things. Prevent much of leakage, much of hemorrhage, much of twisting. So it's very good idea. There's also mini gastric bypass. We start to introduce the bougie and to deflate also the stomach. And started to dissect the lesser omentum 3 to 4 centimeters before the pyloric ring on the lesser curve. This is the thinnest part of the lesser curve, curvature, and this is a very safe site to dissect and to make your window. And this is articulating powered Johnson stapler. It helps us a lot because of flexibility of this stapler. Starting as low as we can to make sure we are doing a very long narrow pouch. The first reload without bougie, and we started to introduce a bougie after the second reload. Then we completed the pouch. And also we dissected the posterior part of the gastric pouch if there is a big vessels, big veins. And then enterotomy behind the staple line. If we found a bulky omentum, we divide it. If it is not heavy, we proceed to do our anastomosis. So after detection of DJ, we running the intestine from proximal to distal. We excluding 2 meters if the body mass index more than 35. Below 35, we did 150, and this is 4 centimeters gastrocnemiectomy, because after closure it will be 3 centimeters. We also trusting the stoma size. If we did more restriction, it will be more beneficial. We are closing the gastroenterostomy by BDS to 0 on a round needle, 26, and then also we are proceeding the bougie and doing methylene blue test. Keep in mind also for anyone to avoid any kinking at the gastrostomy, because it's very common to make a kink or twist at the gastrostomy. Then introducing the tube, the drain, and then go out. There's a short video also for laparoscopic Crohn-White gastric bypass, calculating 6 centimeters from the gastroesophageal junction on the lesser curve, making a window, and it's a perigastric window, perigastric approach, preserving the lesser omentum and lesser curvature vessels and nerves. Then introducing a green reload by powered, a blue reload by a powered stapler. Then one reload transverse and also one reload vertical one. We are trusting in the small pouch in Crohn-White gastric bypass. 50 centimeters below pancreatic limb and 70 below body mass index 35, and if it is more than body mass index more than 35, we use 100 pancreatic limb and 100 raw limb. So after dismantling of the pancreatic limb, we close the enterotomy, the gastrocnemiectomy by BDS to 0, and also doing the raw limb and the enterotomy.
Sir, excellent, really excellent demonstration. Yes.
We did enterotomy like that, 6 centimeters enterotomy. Closing the meso gaps by Berlin to 0. And this is a Peterson defect. It is very important defect to close. So after tying the knot, we took a clip over it. Checking everything, the gastrocnemiectomy is intact. Very nice enterotomy, very nice direction of the enterotomy. You are avoiding many kink because many problems happened in this enterotomy because of the kink. This very intact and very good closure of the meso gaps. And also the Peterson fix is closed well. So this is a short pouch and small one. This also this video
Yeah, please.
running. Okay.
So again, you must click that one. So still, no, you can click to run. Okay.
Okay. Yes. Okay, we can scale that. What's okay. Remove this and finish this. So, and this is a short clip about SASI, single smooth speed ileal bypass. Sorry for that. Yes, yeah, SASI. A very interesting operation. I love it so much, but still, we want more research to see the amount of food passing through the duodenum and the amount of food passing through the gastroileostomy. After doing self gastrectomy, we are targeted now to the ileocecal valve, running the intestine from distal to proximal. Also, calculating 3 meters from the ileocecal valve if the body mass index more than 50 kilogram per square meter. If it is more than 50, we can make it 250 centimeters from the ileocecal valve. We tried a lot of maneuvers to do the gastrorhinostomy, the gastroileostomy. 600 centimeters, dependent one, taking the whole food through the terminal ileum, making a lot of diarrhea, a lot of bad offensive stool. So lastly, we tried this technique. 3 centimeters anterior anastomosis, only 3 centimeters. So we measure about 3 centimeters gastroileostomy from here. Last week I saw a patient coming for me to revise her SASI because the whole food bathing from the gastric pouch to the terminal ileum, and she presented with severe diarrhea and severe bad offensive stool, protein malnutrition, micronutrient deficiency. We are preparing her for reversal of this part. So I think the small and smallest, not to be 6 centimeter dependent, it will divert the whole food from the stomach to the terminal ileum. We tried this and it works well. 3 centimeters and the smallest, it will work well. So you can see now the methylene blue dye passing through the duodenum and also passing through the terminal ileum. It may be a very good option to avoid more complications. And this is the SASI shape. This is also an investigational procedure. We started 4 centimeters, 4 to 6 centimeters from the pyloric ring, doing our steep gastrectomy as usual. 2 green reloads and one gold, and then proceed by 2 till we reach to the angle test above. So we tried this type of anastomosis, like the maneuver that we did in mini gastric bypass, opening in the posterior part of the stable line, taking the omentum also and divide the bulk omentum if it is present. If it is not heavy, we don't do division. Calculating 2 meters only from the DJ. And then we did the anastomosis by making or like mini gastric bypass. Actually, we are doing this procedure nowadays as an investigational procedure only. We don't do it in a private base, and also we did it only for research purpose. So this is very good in smallness. We don't have enough data about the follow-up after SAS-J procedure. Yeah, you can see now the dye buffing through on this, because a lot of cases coming for us because we are doing a lot of revisional surgery. We are a referral center, so we see a lot of cases with kink at this site, and definitely in SASI and also in SAS-J. This also, we did a lot of cases like series in the university, and also it is not a common procedure in the private sector. And you know that we have the main practice in private depend on the private sector. So we did this cases of series in university for also research, because we fear from its devastating complication as vitamin deficiency, protein nutrition, malnutrition, and also diarrhea, and we face a lot of complications from maladapted patients. We don't write or divide the right gastric vessel. We did a sleeve gastrectomy to be lazy sleeve between 20 and 30 cc capacity, and targeting ourselves to the ileocecal valve again, like SASI bypass, calculating the same measurements. But mass index less than 50. In our publication, we did 2.5, 3 meters. If above 50 body mass index, we did 2.5 meters common channel. So the duodenal ileostomy, we did it even hands-on by BDS to 0 or VLOC. It's a very good procedure, but it's not popular in a private sector. This is an insulin blue dye. Okay. So, how can you design the biliopancreatic length? It's a controversial issue, but this is meta-analysis from the Imperial College, November 2022. They did a lot of investigations, a lot of analysis, and they found that they were studying the biliopancreatic length effect of Roux-en-Y gastric bypass and its effect on weight and metabolic effect in morbid obese patients. And they found that no definite evidence to suggest that alteration of the biliopancreatic gland affects the quantity of weight loss or resolution of comorbidity, metabolic comorbidities associated with obesity. So if you have any question about the operative videos, you can share it with us.
Sir, excellent, really excellent demonstration, and in my opinion, it was a comprehensive review of all types of metabolic surgeries. And now just one question. So yes, we will go also in post-op, and now definite Professor Karim did his figure is in tetra, no doubt more than 1,000 and cases. In 2022, just imagine a patient with BMI 33, 50 years old, diabetic patient. So which surgery you will do for the case? There is no contraindication.
50 years old.
50 years old, BMI 33, diabetic patient, healthy, no contraindication, patient is fit for cardiopulmonary, there is no contraindication. Any type, no GERD, no nothing. Which surgery you will go for this case?
I will be away from the guidelines. I will tell you about my practice in this case. If it is 15 years old,
No, 50, 50.
50, it's old.
Yeah. No, not
yeah,
15,
yeah.
50.
50, yeah. Okay. I will assess this patient as regard the Durham score. It's more helpful for me. And also, I will discuss with this patient about the resolution and recurrence of diabetes, because we see a lot of cases underwent laparoscopic mini gastric bypass or gastric bypass, seeking for complete resolution of diabetes, and they recur again and went back to us after 2 to 3 years, complaining from the recurrence of diabetes. So first, I have to discuss with this patient the whole and every thing that we expect for this as regard remission and recurrence. This is the most important thing for me. If I see that the hemoglobin A1C is not bad, and also the C-peptide is very good, I can go for either sleeve gastrectomy or Roux-en-Y gastric bypass or mini gastric bypass. It's all equal for me. If I found that there is a severe reflux, I will exclude sleeve gastrectomy and go for Roux-en-Y gastric bypass. If I found that there is, for example, Crohn's disease, organ transplantation history, or non-steroidal medications for rheumatoid arthritis, anything that prevent me to do bypass surgery, I will go for sleeve gastrectomy. And a lot of meta-analysis and a lot of publications found that there is no difference between the effect of Roux-en-Y gastric bypass and sleeve gastrectomy as regard resolution and recurrence rate of diabetes. They found 5 to 50% only difference in weight loss, but they didn't find any difference as regard comorbidity resolution. So I will conclude that I will go for sleeve if there is no contraindication. If there is contraindication for sleeve, I will go for bypass in this low body mass index, because usually I consider that the patient will not adapting vitamin supplementation, will not adapting the follow-up regimen or schedule. So I'm usually conservative more in body mass index between 30 and 35, and this is my practice. And I see this is in fact, this is right for our population. We have to be conservative more in body mass index between 30 and 35. After that, or over that, body mass index, and I can go for bypass. I love it more than sleeve in higher body mass index.
Sir, excellent. Sir, and another, if you want to choose between Roux-en-Y and MGB, same case, 33, because this is class 1 obesity. Yes, I know when this is morbid obesity or yes, we will be in favor of any type of hypoabsorptive. So, and also the age is also, as I mentioned, is 50 plus. So if you are going to do, so just imagine patient is okay. There is no contraindication. Again, there is no contraindication, no GERD, nothing. And you are going to do, and also C-peptide, everything is fine. Between MGB and Roux-en-Y, which surgery you will select for this case?
I will go for mini gastric bypass. I love it, and I see that this procedure is more effective. Is this, if not the same effect like gastric bypass, I see it's more effective as regard the metabolic effects in my practice. I see a lot of research supposing that it's equal for Roux-en-Y gastric bypass as regard weight and metabolic outcomes, and I see myself it's more preferable. And it is more easier in low body mass index, because we see a lot of cases with low body mass index who have a small working space. So you are choosing the easy procedure, it's not contraindicated. So I will go for mini gastric bypass. I see it's easier. It doesn't have a long-term complications like internal hernias It doesn't take a lot of time during the operation. And also, I see it's a very powerful operation as regard weight loss and metabolic outcomes. So I will go for mini gastric bypass for sure.
Sir, because now in Middle East we are also routinely doing SASI procedure, especially for low BMI diabetic patients. And as you have mentioned also, you are also doing SASI or SAJ. It is enterojejunostomy or enteroileostomy. It depends on the patient BMI. Again, same case. So if there are 3-4 options for you, so patient age, patient is okay. He's oriented person. He's in your access. So yes, he can follow up. He will do. He's not from a village and far from an area, and maybe he will go and will not come back. So then you are, because this is very important for me and for my viewers, a person like you on table, you have all of these 3-4 options. Also you can do SASI, you can go for SAJ, you can go for MGB with this short BP limb. So what you will do? And because one thing that is the most important, you are scientist, you are not only surgeon, because you have a lot of data. You love your patients, and patient safety is more important for us at this stage. So again, when yes, all options are open for you, because when you will go for SASI, definitely you have endoscopic access to duodenum. So that is also a positive thing. Yes, we have also access in MGB from remnant to with the assisted laparoscopic, endoscopic for ERCP, everything. But overall, you have this positive thing for your patient. So according to your this experience and opinion, so what you will choose?
Let me tell you the story of SASI with me. I started to do SASI 2015, and I started to do it every day. And after a lot of cases, thousands of cases in a high volume centers, I found that the patients didn't go on the same pathway as regard weight loss and comorbidity resolution. Part of them are losing weight more than expected. And even some of them return back to me with protein malnutrition, and you see that her legs is swollen. Because I think it was this is because of the large gastroileostomy that diverting the whole food from the stomach to the terminal ileum. The other part of those patients coming to me with weight again, and a lot of cases bathing smoothly, very good. How can I detect these outcomes? So after many medical legal problems that happen in bariatric surgery here in Egypt, I found myself must adapt the guidelines. Only in my practice, I provide the certified procedures. Even the patient asked me to do SASI or SASJ, I will inform this patient that we don't have any tool to assess the percentage of food that will pass through the duodenum and the percentage of food that will pass through the gastroileostomy. So you will write a consent that you will be enrolled in an investigational procedure. If he will agree, and also I asked the patient that he have to know that he will adapt also vitamins as a support for him for life, because many of surgeons around us telling the patient, if you will do SASI, you will not be in need for any vitamins, and we don't have any research to support this. So if I found that the patient writing a consent in front of me and he is convinced by this, and also he is he know that he will take vitamins, I will go for SASI. I think it's a very good procedure. It will take a time and it will be popularized, but we have to assess the percentage of food passing through the duodenum and through the gastroileostomy. This is the only concern in my mind here in my practice. in your patient, he don't have any contraindication for anything. I will go also for many gastric bypass.
Sir, excellent. Excellent.
Except he will agree to write a consent and to adapt vitamins, taking vitamins after the operation.
Sir, excellent, and definitely this will be a great message for our youngsters, because we have lot of our viewers are there newcomers, so must follow that standard technique, must follow international guidelines, because this is the most important. So then yes, in future you can select your patient. Sir, in this part, so we are interested to hear about your follow-up, about your data, your results. So please, sir.
Okay. Sir. This one. So the post-operative care, as regards the post-operative care, we followed the patient 2 weeks, 1 month, 2 months, 6 months, then yearly after that. But actually, we lost about 70 to 80% of our patients in the follow-up. So we follow them as we can. And as regards the percentage of complete remission and recurrence of diabetes, we have to define the remission to be hemoglobin A1C less than 6.5% without glucose-lowering medications, but the improvement only if we found hemoglobin A1C of less than 6.5% with a decrease in dosage of anti-diabetic medications. There's a lot of studies that reveals 78% remission of diabetes after surgery and 87% improvement also after the same surgery. Numerous randomized controlled trials with post-operative follow-up ranging between 1 to 5 years above consistently documented sustained diabetes. They found a remission between 30 and 63 of patients. Available data suggests an erosion of diabetic remission over time. 35 to 30% or more of patients who initially achieve remission of diabetes eventually experience recurrence. And this is a problem. In some cases, you will find and you will face a patient who will come back to you complaining from recurrence of diabetes. You will tell the patient that the comorbidity resolution as regards fatty liver, dyslipidemia, hypertension, and diabetes, this is the whole metabolic syndrome. If there is recurrence of diabetes only, it's not a big problem for you because you are you have a lot of comorbidities which have a remission. So it's not a big deal, and we have to encounter these problems of recurrence. So there is a lot of recurrence, about 32 relapse in type 2 diabetes and median age of 8 years follow-up. There are a lot of predictors of late relapse that include duration of diabetes, number of preoperative anti-diabetic medications, and also for sure type of surgical procedure, because one procedure is more stronger than the other one. The association between longer type 2 diabetes duration and the higher risk of type 2 diabetic relapse following metabolic surgery is important, as it highlights the importance of not impeding patients with type 2 access to metabolic surgery and the need to intervene early in the course. So we need to intervene as early as we can, because the duration of diabetes is very important to predict the rate of recurrence after that. This is the message. Main concern after metabolic surgery, the main challenge is achieving satisfactory post-operative outcome for the patient, according to diarrhea score and advancing diarrhea score, choosing the right procedure, and also to do a patient counseling about the expectation is very, very important. As we said, as we mentioned, the expected results and the possible complications, and also to be cautious regarding the length of the pouch and the length of the biliopancreatic limb. You have to tailor the operation according to your patient. We know that we have a lot of complications like bleeding, stable line leak, which decreased a lot by adapting omental fixation with full thickness stitches in sleeve gastrectomy. And now I am adapting the omental fixation, and we are publishing nowadays in press the omentopexy in double omentopexy in mini gastric bypass. Doing omentopexy to the excluded stomach and also to the new gastric pouch, excluding and decrease the rate of bleeding to the lowest level, and also decrease the stable line leak, and also decrease the rate of twisting in sleeve gastrectomy. Also, we have for sure chronic complication in metabolic surgery like strictures, nutritional deficiencies, especially in severe malabsorptive procedures like serous and also mini gastric bypass and also Romaine gastric bypass, and also we have a rate of GERD in different procedures. So we can make a message for bariatric surgeons who are going to start metabolic surgery in low body mass index. Pre-operative patient counseling is critical for the doctors for setting the expectations regarding post-procedural outcomes and recurrence. This is very, very important. Also, we have to tailor the operation according to the weight. Be cautious regarding the length of the pouch and the biliopancreatic limb, so not to have to reverse the operation in a short time. Also, the last message for me, choose the type of the operation according to the educational awareness and the socioeconomic level of the patient, as malabsorptive procedures needs vitamin and supplementations. This is very, very crucial. And thank you very much for your time. You can ask any question. And
yeah, Professor, really, it was one of the best session. There is no doubt. This is reality, and everything you demonstrate in completely. So from pre-op, from patient selection, and also you highlighted all types of technique. In this short period, I can ask, just in 1 hour, you explain everything. And so this is really a great honor for me, and also it was great opportunity personally for me, for myself, and as well as for my viewers. Really appreciable, and definitely you highlighted also this. This is the main concern that personally also I face. I am facing no patient relapse of diabetes. If patient selection is okay, when you will select proper patient for proper surgery for which patient, definite, then you will face less complication. Sir, really appreciable. So much thanks, and definite in future also we need your support and guidance.
Inshallah, thank you very much again, Dr. Amrar, for this nice time and your kind invitation, and giving me the opportunity to elaborate and to discuss with you these hot topics in your great academy. Actually, thank you very much again for your followers in your great academy. Actually, as I said, you did a lot of effort and a lot of work, great work to spread the knowledge in a respectable way. Actually, thank you very much again and again, and I'm appreciating your work and your time.
Sir, again, so much thanks, and definitely this all is due to support of persons like you. Then we can go ahead. And my viewers, so much thanks, because this all sitting, this interviews, this series, these academic activities is due to your support. And we need your follow-up, and definite we will continue this interview series also, because till December, so now next month is December, we will end this series of metabolic surgery in low BM, and next Tuesday also we will be with another expert of bariatric and metabolic surgery. Sir, again, so much thanks, and hope see you soon in any international event.
Thank you very much.
Thank you, sir. Have a nice time, sir.
Thank you.
Thank you, sir.
Record.